Thanks everyone for coming back for our panel discussion. So I want to introduce Chris Kresser, who is not, yep, everybody. So he needs no introduction, but Chris Kresser is the New York Times best-selling author of the Your Personal Paleo Code, which was just re-released as the Paleo Cure, and creator of chriskresser.com, which is one of the top 25 health-related sites in the world, and he's also co-director of the California Center for Functional Medicine. So I just want to review quickly this panel is going to be entirely driven by your questions, and I realized I didn't mention earlier with Twitter, so if you tweet your questions to @DrAkil, spelled out. I'm not sure if you were tweeting to other people, but yeah, so DOCTORAKIL, that will draw on Twitter for several questions for tonight, and you guys could start, it's basically going to be entirely driven by the audience, so you can start lining up if you have questions. We're going to go with the two microphones, and I would like to start off the panel by just posing a question for the panelists, which is that I see a lot of emphasis in my practice about people who are really somewhat rigid when it comes to paleo, and really figuring out were legumes paleo, for example, or was dairy paleo, and not necessarily emphasizing what works and what's really clinically relevant. And I was just wondering if you could share your perspective on that question.
Go for it.
It's a really bad idea, I think, generally. I've long been a proponent of the concept of this weakest link idea, where we would all get a lot more mileage out of pursuing the thing that we're least likely to pursue, the area of focus that needs the most attention in our life, but we're least likely to pay attention to. And for some of us, that might be stress management. For others, it could be sleep. Still others, it could be social support or spending more time outside or whatever it is. And I found that this obsession with that final 5 or 10% of the diet, or worrying about whether this food was paleo or that food wasn't, is usually a distraction from directing that attention to where it really needs to be directed. And so I usually encourage patients, work with patients to identify what that is in their case, and then try to gently guide them in that direction, and pull back a little bit from this really myopic focus on the extremely minute details of the diet.
I guess the only thing I would throw in with that is it's understandable sometimes when people are pretty over the top with these topics, because like for myself, I was quite sick. Like I thought I was going to die. I think a number of people come into this from a serious health crisis, and they find a methodology that helps them. They find a community that's supportive, and then this stuff gets written into stone tablets, and it becomes a jihadist like activity after that. And I don't really know how to solve that. Like the process of self-transformation can be really powerful, so we need to kind of honor and acknowledge that. But at the same time, those people can be damn annoying also, and drive as many people away as they help. And I don't really have a good answer to that other than what Chris said.
Okay, great. Well, we can open it up to the first questioner.
Hi, my name is Melissa Riley, and I'm a public librarian in San Francisco with a great interest in all of your work. Thank you for being here. It was easy to get here, even though I had to come early to get a place in the second row. So what I would love is, even though this is driven by our questions, for you to engage with each other about differences in your sense of what we can do about the obesity epidemic, either with it could be policy, but I'm particularly interested in suggestions for how individuals can proceed. And if you have, I know that's hard to answer, but it's a way of asking if there are differences that you have that you can actually talk to each other about, and that we get to be privy to that conversation.
I think one thing that I seem to be different than a lot of people, I really like Stefan's recommendation of looking at the way that tobacco was handled. The one thing that I seem to be quite different than a lot of people, though, is that the history of the development of the junk food empire for the Western world its genesis was the subsidization of our food supply at the end of the Cold War, and we had a massive amount of this food kicking around that we had to figure out what to do with it instead of letting it go bad. So we figured out ways of making it have a long shelf life and not spoil, and high fructose corn syrup came out of this, and it was just kind of off and running. So I would really like to see all of the farm subsidies disappear. And then if we do some targeted taxation to goose things in one way, I could maybe be open to that, but I forget which Scandinavian country it was, they recently started taxing butter. And so this is my nervousness of really appealing to centralized authority to try to find this, solve this problem, because they inevitably find the wrong solution. So I tend to be a little bit more market libertarian oriented in that regard, where I would prefer us to just uniformly disband the farm subsidies programs, see what food really costs in an open real market. And this isn't related to your question, but I wanted to throw something out that somebody had mentioned earlier. Paleo oftentimes gets beaten up for catering to the rich. Something that is oftentimes forgotten by folks, though, is that people from developing cultures, it is a sign of affluence to eat refined packaged food. And somehow that fact is completely forgotten, or oftentimes is never even understood, and instead there's some sort of weight of irresponsibility placed on the part of folks like myself because we're catering to the rich. And I have all kinds of thoughts about that, and I'll shut up in a minute. But I would really like folks to consider the fact that when you come from a developing culture, think about the psychological and economic incentives or processes that are going along if making it, if showing that you've done the good thing means that you can feed your family food that is not peasant food, which beans, rice, traditional tortillas, oftentimes, and it depends on which culture you're talking about, that oftentimes from a cultural perspective is looked at as peasant food, and being able to eat refined foods like Westerners is looked at as a sign of success. How do we deal with that?
So I agree with most of what Rob said. So I think, unfortunately for your question, I'm going to have to agree with him on most things. But I think, on the issue of government regulation, I think that's where we're going to see a lot of differences. And I think that's where I would differ with Rob the most. I tend to favor a little bit more intervention. And I think, my basic perspective on this is there's not really a right and a wrong answer. There's just different values. There's different values, and there's different perceptions of politics that would make people want to take one route versus the other. My feeling is basically that there's a certain human nature that is kind of difficult to do anything about, and if you don't nudge people in one way or another, whether it's through subsidies or taxes, or what I mean is changing the agricultural subsidy system or taxation or something, if you're not doing something to nudge people, then I feel like you're not really doing anything on a societal level. That's my opinion. But your question focused, I believe, more on individual things. Any of it? Okay. So I'll just say one thing about that I guess spans both individual and society level. Again, one of the things I mentioned in my talk is that sometimes when we get in a room like this with lots of knowledgeable people who care a lot about food, we lose sight of the fact that a lot of people outside of this room are not even doing the basics. Like not eating highly processed, extremely unhealthy food. Like, people don't drink Coca-Cola because they think it's good for them. They don't eat pizza because they think it's good for them. They eat it because they like it, it's cheap, it's available, etc. So, I think we have to if we're going to change the situation, we can't just say this is unhealthy, because that's not the basis of their decisions to begin with. We have to engage with them in a place that makes them care about it. And I think, if we think about the roots of the obesity epidemic, when people ask me why we have this obesity epidemic, I pause for a long time, and then I give an answer that's perhaps not very satisfying because it's vague. But basically, the answer is that there have been slow but dramatic socioeconomic changes in this country that have changed the way that we interact with food over a long period of time. And those are very deeply ingrained. And I think that people are not growing up with a supportive food culture. I think that's part of it. And then we don't have, a socioeconomic situation that guides our behavior in the right direction as adults either. And I think that's a pretty powerful combination, and I think it's going to take a lot of nudging to remedy that.
Okay, why don't we take your question?
Hi, my name is Deborah Sue Kelvin. I'm an integrative Chinese medicine practitioner in Berkeley, and I was asking Chris a question that we thought we might get a little more information on. I was talking with him about intermittent fasting and how there's some suggestions that for women that is not a best idea, and if he could comment also on, another version that might be a better idea for women to work on that. Some are looking for weight loss, others are looking for just longevity and lean muscle, etc. So thank you.
Sure. Let me see if I can tie this into a brief response to the last question as well. We were talking in the last question mostly about obesity prevention, but I think your question was related to obesity treatment as well. And I think it's important to recognize that the factors that led to the development of obesity in an individual aren't necessarily those that will lead to, reversing those won't necessarily lead to a successful treatment. I found in work with people that, and this won't come as a surprise to anyone, but even if it's true that the obesity epidemic is based on the fact that we're eating more calories, which I think I tend to agree with Stefan in that, eating fewer, telling people at least just to eat fewer calories doesn't tend to work. And there's a lot of complexity that comes with unwinding obesity once it's already present. And just like Dr. Sonnenberg said, once inflammatory bowel disease is present, there's a group of processes that are underway that are difficult to reverse because there's so many interlocking factors. So I just wanted to mention that. In the context of intermittent fasting, which is often recommended as a tool for weight loss and improvement of metabolic markers, I have found that it tends to be less well tolerated by women than by men in general, if we're going to make a generalization. And the reason for that, in my opinion, it comes down to a concept called allostatic load. How many are familiar with that concept? Heard about it? Okay, so it's basically wear and tear. It's the wear and tear on the body that comes from trying to maintain this kind of state of internal balance or homeostasis. There's an energetic cost that the body has to pay to regulate itself in an environment where we're under constant stress. And so intermittent fasting works, the theory is because it's a stressor. It's a stressor that causes something called hormesis, which is a positive adaptation. And so if someone has a background level of stress that's kind of, let's say average, and they add a stressor like intermittent fasting, that can have some benefits. But what if someone is working full-time, is a full-time mom, is staying up late, not getting enough sleep, doing CrossFit 4 times a week, not eating enough calories, not eating enough carbohydrates, drinking coffee 4 times a day? I mean, I could go on, but does that resonate with anyone in here?
I think that is everybody here.
Particularly women. I think culturally I see more women who are in this state of allostatic overload, and when they add intermittent fasting, which is a stressor, it just pushes them over the top. And so something that can be hormetic in someone who's kind of in a state of balance becomes something that actually leads to catabolism or breakdown. And so, like anything else, there's no one-size-fits-all approach, but you really have to, when you think about intermittent fasting, whether for a woman or for a man, you have to consider that general background allostatic load before you make any recommendation.
I'd like to share a brief anecdote as a man. Before I used to practice intermittent fasting twice a week. I would eat one meal a day, and I did really well for that for a year or two until I hit a certain point during grad school where the cumulative sleep loss and work stress pretty much destroyed. I don't know if it's permanent, but it's. I wouldn't say I've totally recovered from it yet, but definitely destroyed my ability to not eat in the morning and feel well. And I think it became obvious to me that forcing myself to do that when my body was clearly responding in a negative way to that was not helping my body. And I think that in my case, it's probably, I would say my tolerance for not eating and fasting has improved over time, but that's, in my particular case, been more from sleeping a lot and eating a lot rather than fasting.
I just want to add one more thing that you made me think of, which is really, really important to understand. Interventions which have a positive short-term effect don't always have a positive long-term effect. If there's like one thing I wish people could really get, it's that. And this is kind of dangerous because someone let's say a woman tries intermittent fasting, they're probably going to feel better for a couple of weeks, when they first do it, or maybe even a couple of months. And then it gets wired into their head, intermittent fasting equals good, because I feel better. And then when they start feeling bad 3 or 4 months later, they don't necessarily make the connection with intermittent fasting because they associate it with improvements in their health. And I think that happens with things like bulletproof coffee. People start doing that, they wake up, they drink a huge thing of coffee with like a half cup of fat in it, and they're like, wow, I feel great, it's amazing. And then 6 months later, they can't fall asleep, they're tossing and turning all night, they have no idea why, and nobody even suggests that it could be that they're drinking just only coffee and fat in the morning and not eating. So it's something that comes up a lot in practice. I just wanted to throw that in there.
Perfect. And that's a good segue to this question from Rachel Knox on Twitter. She asks, what are the best paleo alternatives to caffeine, specifically morning coffee, to help patients feel energized?
Cocaine.
In defense of the seriousness of Rob's comment, I just want to point out that Weston Price observed that the natives in the Andes would carry coca leaves with them. And,
The smartest guy in the room, and it doesn't matter what room he's in, he's the smartest in the room. Chris Masterjohn just out.
They didn't necessarily refine the coca leaves into cocaine, but they would use it to suppress appetite and provide energy for the hikes up the mountain. So I think Rob, we're onto something here.
Anyone else?
I mean, there's a couple of different ways to answer that. One is like the more holistic answer, which is the best way to replace caffeine is to live, eat a diet and live a lifestyle that doesn't require it. To get enough sleep, to exercise the right amount, not too much, not too little, eat a nutrient-dense diet, do all the things that everyone in here knows, that we're supposed to be doing, whether we do them or not. And then, the body, believe it or not, isn't hardwired to need caffeine in the morning to wake up. There is no caffeine deficiency. So that's the broader answer. As a more kind of like practical, how do you transition? Certainly titrating off caffeine with things like green tea and then, twig tea or kukicha, which has lower amounts of caffeine, or pu'er, and, slowly switching from sources of higher caffeine to lower caffeine, and then, doing things like exercising when you first wake up, or even just a
Getting
little
outside.
bit. Yeah, bright light exposure, which activates the suprachiasmatic nucleus and has a pretty profound effect on energy levels. There are little tips and tricks you can do like that, but I think that won't work very well if you're not doing the broader picture.
Okay, your question.
Hi there, my name is KJ Landis, and I'm a local wellness author, and I teach free workshops around the Bay Area to everybody in any community, but mostly seniors and lower economic status. My question for the panel today is, earlier the doctor that left discussed metabolic syndrome and obesity as two separate entities. Can you identify the differences?
Obesity is defined purely on the basis of physical characteristics, so how much fat a person carries. You said obesity and metabolic syndrome, right? Yeah, so obesity is purely a physical definition about how much fat a person carries. Metabolic syndrome is defined by a set of criteria, one of which is abdominal obesity. So one of those is a physical characteristic, and then the rest of them are more physiological characteristics like high blood pressure and differences in blood lipids and things like that. And basically, I guess, to answer your question probably more in the way that you're intending it, they don't necessarily overlap with one another. So there is such a thing as metabolically healthy obesity, where a person is obese, but they don't show the detrimental metabolic effects that are observed in most obese people. So if you just find the average, adult person with obesity, they probably are going to have metabolic syndrome, or at least some components of it. But there is a subset of people who do not. So that's kind of the distinction.
Okay, I'm going to take your question.
Hi, I'm Linda Gruber. I'm a Chinese medicine practitioner in San Francisco. My question is more about SIBO and fiber, and how to work those two for people. How to get enough fiber when you have SIBO and you can't really do the fiber.
Okay, just to repeat the question is about SIBO, or small intestinal bacterial overgrowth, and fiber and the relationship between those.
Okay, so great question. There are two phases to this. One is treatment, and the second is prevention. So treatment of SIBO, if you're taking antimicrobials, there's some pretty convincing evidence that you want fiber to be present in the diet. And I talked about this on a podcast with Dr. Pimentel, who's a global expert in SIBO. And basically, antibiotics and antimicrobials work by inhibiting division, cell division. And so, if there is no food for the microbes, they'll go into a dormant state and they stop dividing. And then they become difficult to kill. And the antibiotics are not effective. And so there's this saying, you've got to feed them to kill them.
Right.
And so when we have patients on antimicrobial protocols, we actually prescribe a fiber supplement, partially hydrolyzed guar gum, which in one study showed that the addition of 5 grams of partially hydrolyzed guar gum improved the efficacy of rifaximin from 62% to 87%, just with the addition of that fiber. After the SIBO has been addressed, though, it becomes a more challenging question if the SIBO continues to recur.
Right.
And in that case, we want to start looking for what is causing SIBO to recur. Is it impairment of the migrating motor complex, or is it some other underlying issue like biotoxins or heavy metals, or something that's structurally affecting the physiology of the gut, such that the normal peristaltic wave can't function, and bacteria continue to grow in the small intestine.
Right. Thank you.
You're welcome.
Yeah, and I would add to that the low FODMAP diet is often recommended for patients with irritable bowel syndrome, a large subset of whom have SIBO, and that's also a diet where, like Chris said, it's for the short term. It's not necessarily a healthy way to eat for life, but that can be a good component as well, the low FODMAP diet.
Thank you.
Okay, you can take your question.
Yes, I'm Joellen, and again, another anthropological question, but this time about my own personal anthropology. Thanks to Claudia Rodin, who wrote a marvelous book some years ago called Jewish Cooking, she did meticulous socio-historical research on the traditional food of Jews all the way back to biblical times. And apart from maybe some more, Cossacks raiding ancestors, as far as I know, I'm 100% Ashkenazi Jew. And so I have a pretty good idea what my ancestors ate. And so a natural tendency would think, well, maybe I should eat that way, but maybe this is a very complex question, but Ashkenazi Jewish women have the highest breast cancer rate in the world. So is there, epidemic?
I know where you're going.
So the thing about, okay, maybe the traditional diet also had something to do with sickle cell anemia in Africa and breast cancer in Ashkenazi Jewish women. Are people researching the connection between food traditions and dysfunctional epigenetics?
There's a great paper, and I'm kind of blanking on the title. I can pull it up here in a little bit, but part of the line from the title is The Omnivore's Real Dilemma, and it actually talks about the development of sickle cell anemia being an outgrowth of the Sweden culture, slash and burn culture. People transitioned from hunting and gathering to clearing jungle areas for tuber harvesting, planting and harvesting. What this did, it created nice areas for the collection of shallow ponds, which made it a great environment for the growth of mosquitoes. And then people started living in thatched huts, which provided habitat for the adult mosquitoes, and it increased this vector of mosquito load and also malarial load. And this is a really challenging thing to deal with, and this ended up theoretically, kind of forcing the selection for sickle cell anemia, which sickle cell anemia itself isn't a benign adaptation. If you have two heterozygous carriers, they have 4 kids. 2 of the kids are likely to die either from not getting the protection or from getting the protection. But then the ones that are heterozygous kids, and they're likely to survive, and the cost-benefit analysis is pretty good. I don't know that people are specifically going out and looking at this stuff with the orientation that you're talking about, but there's quite a lot in the literature that kind of looks at how culture has influenced genetic diversity. And I think that, it's a really interesting insight into, and this is kind of where Paleo painted itself a bit into the caveman corner. Had we been able to call this the evolutionary diet or something like that, then we would have had a lot more room for talking about sickle cell anemia and lactase persistence and whatnot. But it's always a story of trade-offs. And this was a really important point with this paper. And it's interesting, individuals that move to the United States that do not have the malarial load, that sickle cell trait dies off almost immediately.
Okay.
So it's...
I mean, the conclusion for me is that maybe I'm better off eating an Ayurvedic diet and will generally, over time decrease the occurrence of breast cancer in Ashkenazi Jewish women by changing our diet away from the traditional. So that's where I was going with that question.
So, I can add that, I don't know. First of all, I think it's pretty cool that you can look back like that and see what your ancestors have been eating for so long. I think that's really neat. But the other thing I would add is that, as you know, Ashkenazi Jews have a unique genetic history. And every population that has a unique genetic history has its own burden of genetic disorders, its own unique burden. And I know that that's true for I don't know about breast cancer specifically, but I know there are certain specific disorders that tend to occur more frequently, genetic disorders in Ashkenazi populations. And so I don't know whether that applies to breast cancer or not, but I think it's plausible that it could, and that may or may not be connected at all to the diet that person is eating.
I would add one nuance, and unfortunately I'm not familiar with the literature on this specific topic, but generally by the time, and maybe this isn't the case here, but generally by the time we have good data on incidence of diseases, quite often people are not eating what they were eating 50 or 100 or 1,000 years ago. So I would want to know to what degree does the diet of the people in which that was measured actually approximate the traditional diet that you're referencing going back to your ancestors, because if that's not the case, then it may be the case that the traditional diet was protective of the genetic traits rather than the reverse.
Yeah, that's a really good point. And I would add also briefly that breast cancer is something that seems to increase in prevalence in societies as they become more affluent and their diet and lifestyle changes. There are certain things that become more prevalent, certain that become less. But breast cancer is one of those things that becomes a lot more prevalent. So I think just in the general sense, the risk probably does depend to a large degree on not just diet but lifestyle, including reproductive factors like how many children a person is having and how many menstrual cycles are going through in their lifetime, and things like that have all been linked to risk. And those are all novel factors that have occurred since the time of our distant ancestors.
Okay, your question.
My name's Alexander Lee. I'm a filmmaker in LA. And actually, I have two questions. This is just too good of an opportunity to pass up. I have tons of more questions, actually. But my first question is each individual panelist's opinion on this trend of the ketogenic diet, and maybe something you could call the Tim Ferriss effect. Rob Wolf mentioned, an podcast interview with Dr. Peter Attia, also Dom D'Agostino. Certain caveats in terms of that trend. Any personal opinions on that? I would love to hear your guys' take on that. And my second question is also related to, I guess, maybe fat intake. I myself, without going to too much detail, was following a fairly strict paleo diet, and I started adding more fat into my diet, but also increasing my carbohydrate consumption. So I'm wondering if there's this kind of general assumption that you can eat fat and not, get fat from eating fat. You get fat by eating carbs. But if you have both of them, can they lead into some kind of synergistic, increase in bodily fat?
So ketogenic diet, I think that it's an incredibly powerful tool. I haven't spent a lot of time around carpenters or contractors, but I can't imagine that they bitch and snipe and attack one another about whether or not they should use a hammer versus a screwdriver. But people do that constantly within the nutritional scene, and so I see it to be like a hammer or a screwdriver or anything else. It's a tool. It's a fantastic tool. And it's a massively underutilized tool on the one hand, and it's sold as a panacea at other times. And so I'm fighting two battles constantly. On the one hand, it's calming down the low carb jihadis who are trying to make this the uniform, one size fits all for everybody. And then on the other hand, trying to also make people aware that in every medical kit at every youth sport event, there should be some sort of ketone ester salt. And when a kid gets knocked down and they've clearly had some sort of a traumatic brain injury, they should probably be administered a ketone ester. And we should do some randomized control trials to verify this and vet it out. But the mechanism seems pretty plausible that this is going to really limit long-term a traumatic brain injury. There are some great studies in the military. We're not going to see those studies in the military for probably about 6 to 8 years, so we should be doing this stuff on the other side. So there's two things to me for the ketogenic diet. Great tool, gets overused and oversold in certain circumstances, and should be used appropriately. And as Chris has said, for a lot of people, a ketogenic diet is a great initial intervention. And then when it ceases to continue working as per label claims, then we need to shift gears and be okay with that and non-religious about it. 10 years ago, I would have said it was the cure for all problems.
I don't have much. I agree with Rob. I think it's when it works, it's fantastic. And the conditions that I've seen success with tend to fall into neurological, conditions and blood sugar dysregulation conditions. But even then, it doesn't. It's not always the case. I've seen some people who are obese or insulin leptin resistant get worse on ketogenic diets, and I've seen people with neurological conditions get worse on them too. So, there's a theme here, which is there's no one-size-fits-all approach, and experimentation is a completely valid tool, to use both clinically as clinicians, and then, as people just trying to figure out what works best.
So, Chris, unless you have anything to add, I'm going to move on to the second part of that question.
I don't have much to add. I just think that the ketogenic diet does have applications in neurological disorders. I think maybe there are applications outside that are less well established, but I think that I think there's a large crowd of people who are using the ketogenic diet not to treat any particular thing, and I don't think that probably across the span of all traditional diets, they were not ketogenic. There's a possible exception in the Inuit, but I would say that's highly controversial. And I think that the normal natural diet for a healthy person should not be a consistently ketogenic diet. I don't think ketones are bad things. I think we're actually always in a state of ketogenesis in the sense that there's some level of blood ketones that will rise in the morning after you've been sleeping at night. They're not spilling over into the urine, in part because production isn't really high, and in part because you haven't entered a state where your cells are becoming resistant to using everything, including ketones. And when your urinary ketones are rising, it's probably reflecting ketogenesis, but it's probably also reflecting ketone resistance, because a diet that severely restricts protein and carbohydrate also decreases your ability to actually use ketones. And I don't think that makes sense to be a state to be consistently and chronically pursuing if you're not using it as a specific tool to treat a specific thing. So I think it's important, if you're going to use a ketogenic diet, that you actually have a strong rationale to use it for something for which it's been demonstrated to be purposeful.
Yeah, I mean, just briefly, I basically agree with that. I think it's not very ancestral, and so I view it kind of almost like a drug. It's something that has efficacy in certain situations, but it's not really the physiological baseline for most, if not all humans. So let me paraphrase your second question to make sure I still remember what it was. You were saying, you were asking whether the combination of fat and carbohydrate is more fattening than a diet that's mostly fat or mostly carbohydrate. Yeah, I mean, I think it is, and I really don't think we need to invoke too many complex physiological mechanisms to explain it. The human body is a master at utilizing whatever fuels are coming into it. And so it can shift very fluidly between carbohydrate as a fuel, fat as a fuel, and any ratio in between of those. So from a purely thermodynamic standpoint, it really matters very little where you are. It might matter a little bit at the extremes, but it matters very little. But where it does matter is in the amount of food that you're going to eat. So if you have food that has very little carbohydrate or has very little fat, you're going to eat fewer calories in general, because the most palatable foods, the foods that drive us to eat the most, are foods that combine fat and carbohydrate. Like, if you look at a food like ice cream, you know, depending on who you ask, that's either a high-fat food or it's a high-sugar food, depending on what nutrient that particular person prefers to demonize.
I love ice
the
cream.
reality is, what's that?
Have you ever tried Jenny's blended ice cream?
I'm sorry, I didn't hear what you said.
Oh, I said, have you ever tried Jenny's blended ice cream?
No, what's that?
It's grass-fed milk. It's
Oh, okay, all right. So, all right.
Where can we get it?
But anyway, the point I'm trying to make is if you have ice cream that has no sugar in it, it's not very good. If you have ice cream that has no fat in it, it's also not very good. So you need the sugar and the fat for that to really hit that sweet spot. And to have a maximum dietary breadth, dietary variety, as well as palatability and calorie density, the easiest way to hit that is to have a wide variety of fat and carbohydrate-rich foods. And so I think that middle ground is basically just the easiest place for us to overeat.
Okay, so we have a question from Twitter. So a Balance Table wants to know, what are the panelists' thoughts on the fermented cod liver oil controversy and recommendations about that?
I'm happy to talk about it too. I'll just speak briefly and then you can follow up. I think it's another one of these situations that Rob referred to with the carpenters and the nails and hammers. I think it's been blown way out of proportion, and there's a lot of ego and politics involved. And when I looked into it in some detail, I came away with the conclusion that some people may be sensitive to the amines in fermented cod liver oil. And they may react to it for that reason, but I didn't see anything that convinced me that it was toxic or harmful to the general population, or even the general sick population who's not sensitive to amines. That's pretty much where I got to.
I think Chris and I came to a pretty similar conclusion.
Sorry.
On a practical level, I think you can try the fermented cod liver oil, and you can try non-fermented cod liver oil and decide which one seems to work better.
Yeah, I mean, I do have patients that don't react well to the fermented cod liver oil, but I do believe it's because of the amines, not histamine actually, because the histamine levels are not particularly high in cod liver oil or fermented cod liver oil, but other amines may be problematic. And there are alternatives like extra virgin cod liver oil, which we use in those situations, and I actually just prefer that myself at this point, but it's not because I believe that fermented cod liver oil is bad or harmful. So.
Can you say a word about what the amines are, just for people who are not familiar with those?
Amines are microbial derivatives of amino acids usually, and there's a lot of, in fermented foods in general, there's usually some levels of certain amines, and they can have bioactive effects, and so in some people who are sensitive to them because they don't get rid of them as well, eating amines in foods, which is usually coming from fermented foods, could be associated with a variety of symptoms depending on the particular sensitivity and the particular amine, and that could be migraines, or it could be heart palpitations, or it could be skin irritation. In the fermented cod liver oil, there's not histamine, but scombroid poisoning would be an example of amine toxicity that could affect anyone, and that happens when salmon is poorly preserved and develops a lot of histamine, and you have vomiting and diarrhea from that. That would be an example of a high amine load, but generally all the fermented foods have smaller levels of amines, and so a subset of the population who's particularly sensitive might have negative reactions to those.
There's one more thing I want to add. It's important, I think, to understand the power of the nocebo effect. Anyone heard of that? Nocebo? So it's the opposite of placebo effect. And so an example of this would be in studies. They've done studies where they've given, one example is they give a placebo, sugar pill to two groups of men, and one group of men, and they told them it was for erectile dysfunction, it was finasteride, which is for baldness. And for one group of men, they didn't say anything about side effects that it has. And the other group of men, they said, this drug can cause erectile dysfunction. And in the group of men that didn't receive any counsel about side effects, 3% reported experiencing erectile dysfunction as a result of taking the sugar pill. And in the group that was advised that erectile dysfunction was a side effect, 35% experienced erectile dysfunction. So this is a very real phenomenon, and there was this whole thing with the fermented cod liver oil controversy where people who were advocating, were claiming that it was bad, were saying, how can all these people, look at all these people who are writing in and saying that they were harmed by cod liver oil, by taking them fermented cod liver oil. That's not very scientific as a means of, figuring this out, and it's just something that it's a real phenomenon. And so you get this meme out there that fermented cod liver oil is causing problems, and all these people start writing in and reporting their issues. It's hard to, it's not that I don't take that seriously, it's just not very rigorous.
Great. Okay, why don't we take your question?
Hi there, my name is Zoe and I'm a first-year med student here at UCSF. There's been a lot of bashing of science and evidence-based medicine today, as well as, presentations that were exclusively evidence-based medicine. I was wondering if you guys could just clarify your positions on what kind of science passes the smell test for you and how you approach reading a paper or talking to a scientist or a journalist about these types of issues to help you determine what you think is okay and what isn't, and what is quackery and what is real. Thanks.
I have something for that. So evidence-based medicine takes attempts to construct a hierarchy of different types of evidence that can be used for establishing treatments, and places randomized controlled trials near the top, and places systematic reviews and meta-analyses of randomized controlled trials at the very top. And I think that randomized controlled trials are the gold standard of understanding whether a treatment has a cause and effect relationship related to some outcome in humans, and I think that they're very important. I think evidence-based medicine does a great job of constructing a hierarchy that will help elucidate how confident we should be that a particular treatment is going to have a particular effect. I think what evidence-based medicine doesn't do very well is construct a means of deciding what to do in the face of always uncertain evidence. And so the evidence basis is always limited. Randomized controlled trials have a large set of limitations that include that they're usually shorter in duration and in a less realistic context than what other forms of evidence could produce. And so if our information is always limited, we always need to decide what to do. And what to do is, there's a subjective component to that depends on your values and doesn't just depend on your level of certainty in cause and effect relationships. And so I think if you want to decide what to do about something, you need to look at evidence more holistically, and you need to integrate your own subjective value judgments. And I think that in trying to understand something, it makes sense to look. I think every type of evidence has their own strengths and limitations, And even anecdotes can be very valuable if you can interpret them in the context of what we know from other types of evidence. So I don't think it makes any sense at all to only focus on randomized controlled trials as our basis for trying to understand the world around us.
That was outstanding. I guess, and a fantastic question. I guess maybe you picked up on probably some of my frustration with the evidence-based medicine scene. What I've seen them do is play both sides of the fence. When they want to argue their position, they will kind of retreat behind a wall that a lack of evidence is evidence of lack, which I've found incredibly frustrating. We've had just some really interesting points in kind of medical history, like when the guy discovered that folate deficiency may have a tie to neural tube defects. The guy was so ridiculed and laughed off the scene that he lost his lab and went from like a prestigious lab to like a Kentucky lab of nutritional research kind of thing. And then years go by, and then eventually everybody says, oh yeah, this is totally accurate. And the guy's career is ruined, and the H. pylori, kind of a similar, much similar example. Emil Semmelweis, who made the audacious recommendation that you should wash your hands between autopsies and delivering babies. So, medicine is riddled with stuff like that. But we are also, I'm a huge fan of like Carl Sagan, the demon-haunted world. And to your point, every idea that comes down the pipe should not be given equal credibility. But where we see a proposed mechanism, but yet say, let's say a paucity of randomized control trials really be able to hang our hat on, I'm just throwing the idea out there that maybe we could give that a little bit of airplay besides shutting it down outright. And that's really my push in that regard. And and that would,
One of the things I like to say about science is it's the history of most scientists being wrong about most things most of the time. And that doesn't invalidate science, and because I think that's kind of built into the scientific method, and is to continually question our assumptions. And as long as we're willing to do that, and be honest with ourselves about what we don't know, and to challenge even what we think we know, then the science, I love science. I think everyone at this table spends a large percentage of their time reading scientific studies and appreciates deeply what they contribute to our understanding. But if we don't remember that, when we kind of look back at scientists 100 years ago and kind of chuckle at what they thought was true, we have to remember that people, scientists 100 years ahead of us are going to probably do the same thing. So some of our most cherished beliefs are going to turn out to be completely false. And so I think there's some humility that's lacking in the evidence-based medicine scene. And that's what gets us, well, speaking personally, gets me a little riled up.
Okay, you can take your question.
Hi, my name is Christina. I'm the founder of a company that helps people follow paleo diets by providing them with personalized meal plans and grocery lists. It's called platejoy.com. My question is for those of you who are kind of more in the clinical world, what are some of the things that you see long-term patients who switch to paleo diets, some of the negative symptoms that they may start to exhibit? And I'm not talking like the first 2 weeks, low energy, but maybe 3 or 4 months down the line. Is it, increased headaches or digestive issues? And if you see those problems, what are the most common causes and then the most common ways to kind of bypass them?
I really consistently see people under-eating carbs and not being willing to go back out and explore outside of paleo land and check out some legumes and check out some grains, maybe even fermented grains. My goal has always been, and again, like I play both sides of this fence, when I'm talking to one group, it's kind of like, give this thing a shot. And then when I'm talking to the paleo converted, it's kind of like, okay, cool your heels, and let's try getting some more variety in here. So I'm always kind of flipping hats. But I would say consistently that folks end up overly limiting their food options, and particularly carbohydrate. Like initially, if somebody's kind of metabolically broken, maybe they have some SIBO or something, that limited carbohydrate intake may be beneficial in the short run. And then when that fails, they're unwilling to jettison that and try something new.
And here are the symptoms of that. Insomnia, poor sleep, low energy, afternoon energy crashes, poor exercise tolerance, poor exercise recovery, shifts in mood, brain fog, cognitive issues. I would agree strongly with what Rob said. I see this, that's the first thing I think about, and I was just sharing a story with Stefan and Chris at lunch about someone who I was treating that, had basically traveled all around the country. He's a pretty high-profile person, and had gone to the Mayo Clinic and had spent, probably over $100,000 talking to specialists of all kinds. And when he came to me, I do a diet survey, and everyone who comes in, and I knew just from who he is, his activity levels, and I told him to eat more carbohydrates, and it pretty much fixed his problems. Not all of them. There's still some issues, but after spending $100,000 and seeing all these top specialists, he was pretty frustrated by that in a way. But it can be a really powerful thing. And I would add the second thing is actually just not eating enough. I work with a couple of nutritionists, some of you know them, and they will actually do the calculation of what people are eating in terms of their overall calorie intake. And I would say a significant number of people are 20% below their calorie needs. And my practice is unusual. I'm not seeing, I don't see a lot of people who are on the obese, overweight end of the spectrum. But just not eating enough because their food choices are so limited.
And when you say eating more carbohydrates, is this for people that are below, say, 50 grams per day? Is there some sort of level, or can it be very variable?
Well, I would put it in terms of percentage of calories, So let's say I wrote an article about the accidental low-carb diet, because what happens is, people are eating bread and pasta and soda and all of this stuff that's very high in carbohydrates. They go paleo, and then somehow it got early on co-opted by the low-carb movement. So the idea of paleo was just meat and non-starchy vegetables. And so I see they eat eggs and bacon for breakfast, they eat a salad with some chicken for lunch, and they eat dinner, like meat or fish and some broccoli and half of a sweet potato. And guess what? For most people, that's going to be less than 10% of calories is carbohydrate. That's a super low-carb diet. And so I have to I have to tell people you need to have a serving of, a larger serving of starch at every meal or some fruit in between meals in order to keep your carbohydrate intake up, because a lot of people didn't even intend to do that. They didn't even intend to go on a low-carb diet, but they are on one. And then they don't find out until they feel like crap, 4 months later.
I was feeling kind of run down, and I ate what I thought was a decent amount of food, decent amount of carbs. I ate sweet potatoes and fruit and whatnot. And I thought, I'll break out the food measuring devices. And I was eating about 1,700 calories a day, doing jujitsu 4 days a week, lifting weights twice, 2 kids. And I was like, no wonder I feel like crap, And the basal calculations for me, the muscle mass I carry was about 3,200 calories. So I maybe could have lived 150 years doing that, because I was at Roy Walford level of caloric restriction. But this is, both a power and a curse of kind of eating this way. I wasn't necessarily hungry. I had to really get in and think about okay, so what else am I going to have? And with my sweet potato, I started taking applesauce and mixing it in there and putting some cinnamon on it, making my food a little more hyper palatable, to pull some stuff from Stefan's work, and it's really not hyper palatable, but I had to really think about how am I going to, beef this stuff up so that my total caloric load is greater.
I agree with everything that's been said, and I don't have a clinical practice, but I do a small number of consultations which are biased in general towards people who want to talk about blood lipids, and so I would put on the list adverse changes to people's blood lipids, and I would put on the list in females lack of menstruation in some cases. And I would say that in addition to accidentally going low carb and low calorie from restricting food categories and not compensating for that, I think that a lot of people who exercise have no idea how their exercise is affecting their carbohydrate requirements. And so I talked to a guy who did CrossFit like 5 times a week and was eating, I think, definitely under 50 grams of carbs a day, but I think it was a lot lower than that. But we're talking about doing exercise that heavily taxes glycogen supplies and eating like 1/10 of what would replete the glycogen supply. And so it seemed obviously, based on basic math, his glycogen stores would have to be really low. And the primary problem that he wanted to talk about was that every morning at about 4:30 in the morning, he would slam up awake with his heart beating, having to pee a lot, and all sorts of like classic stress hormone responses. And it seemed almost obvious that if you are doing high intensity exercise and not repleting your glycogen stores even coming close to doing that, that you're not going to have enough glycogen to maintain your blood sugar over the night, and that your stress hormones are going to get elevated. So I think a lot of people could use a better understanding of how their exercise regimen is impacting their carbohydrate requirements.
Okay, thanks. We have a question from Dr. Joshua Russell, who asks, how do you recommend a busy practitioner efficiently keep up with changes in the scientific literature and our understanding of nutrition and disease?
Listen to Chris Kresser's podcast. Because he gets more done than like 50 people.
That's a good question. Yeah, I'm not sure. I don't know. I mean, there are certainly like newer services like Examine.com that are collating research, and they're looking at it from an evolutionary functional perspective. And I like their work a lot. They provide a good service. But really, there isn't any, somebody asked this in my clinician training program as well recently, like, in conventional medicine we have resources like UpToDate and services that go out and analyze the literature and come back with recommendations, but we don't have an equivalent service like that in the world of functional medicine or, even evolutionary or ancestral health. Not yet, at least. I mean, we all have blogs and do our best to contribute, but there isn't really like an aggregator that a busy clinician can just say, oh, okay, I'll go check this, and find out what the kind of ancestral functional consensus is on that issue. That doesn't exist. So right now, it's kind of, you're left to pick bloggers that you like, and personally, I have about 1 million RSS feeds set up in PubMed, so that whenever a study is published on a subject that I'm interested in, I read it, but I know that's not really practical for a lot of full-time clinicians.
Your question. Hi, my name is Angeles, and I teach somatic yoga therapy, and I have this moonshot idea. I've been conversing with a lot of machine learning people to help people who are housebound using machine learning and to personalize their yoga therapy experience. And the reason I mention this is because I'm trying to figure out through research, because research doesn't seem to be specific enough right now on the applications of specific types of meditation and yoga for specific types of conditions. And I know like physical and emotional pain activates similar parts of the brain, and also the traumatic brain injury can affect AI, and I have an autoimmune condition. This is how I got into somatic yoga therapy. It was one of the few things that really helped connect me back into my body, and to think about long-term decision-making versus short-term, because I was so in pain and so tired. And I was better at it too. And there's not a lot of opportunities to help yourself in a community arrangement from your home. And so I'm really on a quest to creating something like this and working with people on this. And so do you guys have information outside of historical applications of yoga therapy and meditation on how to help people specifically in different types of conditions? Because I don't see it in the research that I'm looking at. And the second part is, what is your thoughts on long-term and short-term applications of POT with autoimmune conditions? Because I find a lot of doctors tend to not talk about that or not encourage that, but I see with my clients sometimes short-term, the POT can really help them get moving, but that's from my personal observation, so, yeah.
So there is a fair amount of research on meditation for specific diseases and conditions. I'm not sure if they're the ones that you're talking about, but for example, there's a study that stands out in my mind on African-American men who had already had a heart attack and who did transcendental meditation and who experienced a decrease in subsequent heart attacks that was superior to statin therapy. So there are some studies out there that correlate meditation with particular outcomes in particular disease states, but I'm not aware of anything in the realm that you're speaking of, particular.
There's definitely great research, like CBD oil extracts for a huge number of conditions. It seems to modulate the opioid receptors, seem to have some influence on, in addition to the cannabinoid receptors, but effects on the immune response. And it's interesting because it seems to work in a broad acting fashion. It works on the gut, it works systemically, it seems to reduce inflammation. It looks a lot like sleep, food, exercise, gut biome, so I think that's part of the reason why it works so well. It's working. It reminds me a little bit of metformin in that its activity is global.
I haven't used the CBD oil as much in my practice, but my co-director, Dr. Schweig, who's here, actually has some experience with it, so maybe he'd be willing to talk to you.
Thank you.
Okay, your question.
My name's Andy. I don't have any medical experience to speak of, and I feel like I need a beta blocker because my heart's beating out of my chest. Because I feel like I'm talking to movie stars. But
You are not talking to movie stars. You need to seriously increase your standards.
So anyways, I have a question. And from a layman's stance, I guess, my mother recently diagnosed with like mild cognitive decline, Alzheimer's type. And so my question, I guess, is I listen to all your guys' podcasts, blogs, all that stuff, so I kind of understand your views, but the ketogenic diet for stuff like that versus being like an APOE4. So it seems like there's some contradiction there because of the fact that the fat load or maybe cholesterol can't be carried as well by the APOE4, and she's a 4-3, which kind of seems in my mind, from the layman's stance, I'm having trouble seeing I see the benefits of the backdooring maybe the brain fuel with maybe ketones, but at the same time, I'm having trouble if you're putting that much fat in and the cholesterol, then maybe it's doing some damage because the APOE4 can't maybe handle that. So I was wondering what your thoughts, and maybe I'm just way too broad with this, but what your thoughts on that was.
That's a great question.
Yeah, I have some thoughts, and I'm sure everyone else does too. That's a scenario where the ketogenic diet has shown a lot of benefit, actually, in studies, especially with earlier onset dementia. I've had some success with that, actually, in my practice with a few elderly patients who were experiencing early onset dementia and in some cases slowed, and in a couple cases dramatically slowed the progression of it. As to the ApoE question, this has been a few years since I looked into this in detail, but when I did, I found several studies suggesting that the reason that ApoE 3-4 and 4-4 is associated with higher risk of dementia and Alzheimer's and other cognitive issues is actually more related to oxidative damage and inflammation, the increased levels of each of those in ApoE3, 4, and 4,4 carriers than their response to dietary fat. But it's been a few years since I've looked into that, and I'm curious if anyone else.
I think some of the trade-off there is that they're prone also to cardiovascular disease.
Right.
And they might be a subfraction of folks that don't do as well with certain types of saturated fat. I think a possible workaround with that is trying to construct a ketogenic diet that focuses more on monounsaturated fats, and then possibly really liberal use of MCT oils, which don't seem to cause that same problem. So this is maybe less bacon and eggs ketogenic diet and more like salmon and avocado and olive oil kind of ketogenic
Yeah,
diet.
I think that's, sorry to keep going on, but that's kind of where the issue was for me, was like, how do you modify that diet to keep it higher fat? Maybe monounsaturated fats, but at the same time, it's kind of like, it's hard to already get somebody to eat a paleo diet. So now you eat high fat, but wait, you can't eat those ones. You can only eat these ones.
It's tough. Compliance is difficult, especially because with dementia, you know, it's already hard enough when someone is of completely sound mind, but it takes a lot of support from family
and I think
members.
Stefan alluded earlier, the changes in the palate sensing and whatnot with some of these neurodegenerative diseases where they tend to seek out hyperpalatable foods. So, yeah.
They don't recognize me.
I have a small something to add. It's been too long since I've been immersed in Alzheimer's research to comment really directly on Alzheimer's, but Rob made a good point about the MCT oil, because there's basically, but those are sort of two independent strategies of raising ketone production. So so usually insulin from a mixed diet would suppress ketogenesis, but the fatty acids that are 10 or fewer carbons, such as is found in MCT oil, are immune to that suppression. So you can actually increase ketone production without a high-fat diet by including MCT oil in the diet. Years ago, I saw a talk by someone whose husband was, and unfortunately I'm blanking on the name, but it was a presentation by someone who's...
She's an MD. Yeah, I'm
Newport?
blanking on the name.
Yeah,
Newport.
Newport.
Very Newport. Very Newport.
So I didn't follow that case, but she was reporting some initial progress by including coconut oil.
It was 10 people, and 10 people were in the study.
Oh,
yeah.
So you claim that there was no medical background here. I call foul, sir.
It's just you guys. and the way you interview each other.
So what happened to 10 people?
About 8 of them, so they were all, there was, and I'm off a lot, I'm sure, but this is the general, I think, story here. They did a ton of different testing, and there was the APOE was part of the categorization, but at the same time they did a lot of coconut oil in that study, and then they also did a lot of supplementation as well. So there was a lot of methyl B12 and the basic B vitamins, and then there was the omega-3s, whether they're in the fish oil form or whatever, and they were going down just hitting the basic gamut of vitamins that would be deficient in a diet, D, K2, all those things. And so then a lot of them actually got their licenses back. I think 3 or 4 of them ended up getting their licenses back because only a couple of them were in severe Alzheimer's. Most of them were in the mild cognitive decline state, so they were able to kind of nourish them back enough to get to a state where they were able to pass the criteria that, you know, the conventional medicine model says you have this or you don't have this. So sorry to drag on, but that's kind of
that's great. I'd make one final point on that, which is that coconut oil is only 15% of the fatty acids in coconut oil are short enough to have that effect, and so if it's a less borderline case where you're trying to get a stronger effect, you could get approximately 6 or so times the effect of including, or get the same effect by including a smaller amount of MCT oil in the diet. I mean, coconut oil, I think in general is preferable because it's more natural, but if you're trying to treat something specific and it's dependent upon getting trying to increase ketone levels and keep the fat level low, MCT oil would be more effective, much more effective than coconut oil would be in that case.
What about exogenous ketones?
That would be another way to approach that.
Okay, I was just wondering. Because when I have to talk to a doctor, I have a problem because he doesn't agree with any of this, obviously.
Peter Attia told me that exogenous ketones taste like jet fuel, so you might have a hard time convincing me to take that.
You don't have gummy bear flavor?
Thanks.
Thank you.
Okay, your question.
I am Candace. I'm a nutrition geek and a musician. My question has to do with sustainability. And I used to be vegan for sustainability and what I thought health reasons, and now I'm paleo. I feel amazing. I try to get my meat from the green source for seafood watch list, the grass-fed, the everything. I even have eaten insects. Then the question is I have a lot of friends who are just like, oh, paleo, it's not sustainable. I'm not going to try it. Like, this is not okay for the environment. I'd like to know your thoughts on this and what we can do to make paleo more sustainable.
This is the question that has largely ruined my nutritional career because I'm actually super fired up about the sustainability. I don't think row crops are sustainable. Corn, soy, as it's historically done. Alan Savory did kind of a back of the envelope calculation, but he looked at how valuable the food is that we produce and then how much topsoil we are losing. And that means how much lesser food we can ultimately produce. And he makes the argument that the most costly export that the United States has is all the topsoil that we blow into the air and wash down the rivers. And so I'm going to hit a couple of different things here. 1/3 of the planet's landmass is covered in grasslands that are suitable only for large grazing animals to inhabit them, and historically they've done that throughout all of history. We've altered that environment a lot. We've tried to use them for farming with pretty poor success. I think that there's a lot to be had from permaculture, things like the Savory Institute, Polyface Farms, but it's politically and I guess kind of academically right now really lowbrow to say that having animals consume grass from sunlight, produced via photosynthesis, nutrifying the soil, growing the soil, sequestering carbon and nitrogen, decreasing the heat footprint, improving water retention really isn't that sexy, but growing meat in a building in a vat is sexy, and people are kind of duped with this idea that like Soylent and Petri dish meat are somehow sustainable. And what we're working on is trying to do what's called life cycle analysis on these products. And this is basically a full thermodynamic accounting for these foods, and they're incredibly expensive to do well. But we've gotten some funding to do that, and we found the right people to do that, and so we're slowly starting to chip away at some of those stories. So there's a lot of claims out there that I think that we have some, I just have the sneaky suspicion that photosynthesis is going to be, harvesting, processing, concentrating soy protein and then turning it into a shake, and that's going to be the solution for global hunger.
I'm going to say something unpopular. I think that most paleo diets are not very sustainable. That's my opinion. And I think that if you look through the history of human food systems from the beginning of agriculture, meat has always been an expensive, resource-intensive, prized item. And I think that's still true today. It's more resource intensive to produce, and I don't think that's really going to change. And if we, but that being said, and there is some gray area. There's grass-fed meat. I think that there's a lot of back and forth and a lot of polarization about what exactly the environmental impact is of grass-fed meat versus conventional, beef, for example. And I don't claim to be an expert in that area, so I'm not going to come to any conclusions. But I think that the industrial food system, for all the problems that it has built up tremendous efficiencies of scale. and that applies both to meat and to regular grain-based agriculture with grains and legumes. If you look at the carbon footprint of grains and legumes, are very, very low. And the second point I want to make is that a paleo diet is not necessarily a high meat diet. So I think that there are ways to eat a paleo diet that are consistent with almost any paleo recommendations that are, not high in meat and that are very environmentally sustainable. Another point I'll make that's a little bit tangential, but I think is relevant here, is that, when you look at the carbon footprint of meat versus vegetables, like let's say you're talking about a low carbon footprint meat like chicken, and you're comparing that to vegetables, on a calorie for calorie basis, meat is more environmentally efficient than vegetables, because vegetables take up a lot of land, they take up a lot of water, fertilizer, and they're not very rich in calories. So I think that, so the question is, why do we eat meat or why do we eat vegetables? And the answer basically boils down to, we like them and they're nutritious. And so, if you wanted to have the minimum environmental impacts, you could, the smallest possible carbon footprint, you could eat nothing but, wheat and beans. But I don't think most people would consider that to be a healthy, varied diet.
Thank you.
Okay, so we have time for one more question. Go ahead.
Thank you. My name is Amanda. I'm a speech-language pathologist, and I've been plagued by my own health issues, and I am finding myself wanting to be a functional medicine practitioner of some sort, not necessarily a physician, but I would probably like to create a new career to be a functional speech-language pathologist or something. That's my dream at this point. And Chris, I know you have your training going on, so I was thinking of trying to get into that maybe the next round or so. But if you guys had any other recommendations in terms of how someone like me, I'm sort of in the healthcare field at this point, sort of not, but I'm thinking of focusing on neurodevelopmental disabilities such as autism to start with.
Yeah, congratulations, and great, we need you. I think I get this question a lot, and I think one of the most important things to decide early on is just how you want to spend time with people, in a clinical capacity. If it's your goal to order labs and interpret labs and make diagnoses and prescribe either medication or supplements based on those lab results, then you'll need some kind of professional license, and that so that takes you into the realm of physician, naturopathic physician, nurse practitioner, physician assistant, acupuncturist in California, but not in other states necessarily, chiropractor, licensed professionals. If what you want to, if you don't really care about being able to order labs and do all that stuff, and you just want to work with people on their nutrition and their maintenance supplementation and exposome, lifestyle, stress, sleep, all of that stuff, you don't really need a license to do that, and you can save yourself a lot of time and money by just doing the training that would give you the skills to be able to do that kind of work. So that's the first decision you need to make, I think, when you're deciding to pursue a career in this field. And then if you decide to go into a licensed profession, you need to figure out which of those licenses is going to suit you best, and that's largely a personal preference. And I think probably the shortest route, depending on whether you have the prerequisites, would be the accelerated nurse practitioner or physician assistant programs that you can do pretty quickly now. And you have a lot of latitude from a scope of practice perspective there. Lots of privileges, and you have to work under the supervision of a physician, but you can do almost everything that a physician can do in that context. So those are just some ideas.
And in those situations, I could have my own practice and run independently?
Yeah, you can. You do need to be under supervision, but you can have your own practice.
Okay.
Yeah.
Thank you.
There are actually several physician assistant and nurse practitioners in my training program now that are doing that.
Cool.
And there is also the Institute for Functional Medicine, which provides a lot of training, not necessarily with an evolutionary focus, but still, very good quality training in functional medicine. There's also a fellowship in integrative medicine through the University of Arizona. There's also a new fellowship, which Tirone Lodog, who's an MD, is kind of running that through the Academy of Integrative Health and Medicine, and that's open to all types of health professionals, any ranging from nutritionist, dietitian, to MD, to even Chinese medicine. So there's more and more programs coming up. So I just encourage you to find out what's a good fit for you.
Cool. Thank you.
So let's give our panelists a round of applause.